Okay, great. So then hi everyone. I'll be starting now. If just check that everyone is in. Okay, we have 30 participants. So welcome everyone. I'm glad to introduce today's IHSP's webinar. The talk we'll hear is on the social determinants of health and well-being in the context of childhood neurodisability. It's part of our policy talks at the Institute for Health and Social Policy. I also thank our co-hosts, the Center for Research on Families and Children and the Department of Sociology, as well as our speakers, whom I will now introduce. After completing her PhD at the London School of Economics and King's College London, Dr. Angela Marques Philippe held fellowships at the London School of Hygiene and Tropical Medicine and the Center for Social Studies in Portugal. She then joined McGill as a postdoctoral research associate at the Department of Sociology. She's also an associate member of the Department of Anthropology at Laval, a co-investigator on a 5-year CIHR project on the epigenetics of neurobiological risk, and a member of the Wellcome Trust Biosocial Birth Cohort Research Network based in the UK. Her research and teaching expertise span the fields of medical sociology and anthropology, global and mental health, and the social studies of science, thus making a crucial bridge between the health sciences and the health humanities. The other speaker, Dr. Lucyna Lach, is a professor in the School of Social Work here at McGill and an associate member of the Departments of Pediatrics and Neurology, Neurosurgery in the Faculty of Medicine. Her program of research focuses on the quality of life of children with neurodisabilities and their caregivers, and her current projects address social determinants of health of children with neurodisabilities. She is co-leading a team of researchers and trainees who are using population-based as well as administrative and clinical databases to document determinants such as income, service use, and educational outcomes. She is part of a recently funded strategic patient-oriented research team entitled Child Bright, as co-lead of one of 3 themes that is evaluating 5 intervention/prevention approaches to supporting children with neurodisabilities and their families. Dr. Lach and Felipe therefore draw their presentation from a rich array of experiences and research, and I look forward to learning from them. I now turn it over to you, Dr. Felipe and Professor Lach.
Thank you very much, Jonas, for that lovely introduction. I'm going to be starting, and Angela and I will be going back and forth with the different slides and different parts, component parts of this presentation. So I wanted to start, I guess, with a bit of a backdrop as to why we embarked on this project in the first place. One of the things that I didn't mention, or Jonas didn't mention in his introduction, that it's also been funded by Kids Brain Health Network, which is an NCE here in Canada, National Center of Excellence and there are a number of projects that are associated with that NCE, with that network. And they're in their second round of funding, they really emphasized the importance of social context in relation to clinical research, and kept referring to it as social determinants of health and how important they are in the lives of children with neurodisabilities, and kept throwing around the term SDoH, but really, what was SDoH in relation to these children? And so they developed, in fact, quite an imperative to not only document things like income trajectories, educational outcomes, marital status, family well-being, social support, the various indicators of typical indicators of social determinants, but also to understand how and to grapple with this idea of social determinants and how it maps onto a population that actually already has what we would call an illness. In other words, children with neurodisabilities. So Dr. David Nicholas at the University of Calgary and I were the co-principal investigators on this project, and we brought together all kinds of very talented people, including Frank Elgar from IHSP, to work with us on documenting empirically the social determinants, but also we brought together a team with Dr. Bogosian, who's now at the University of Montreal, Dr. Zula from the University of Calgary, and of course, Dr. Felipe, to help us to think about how this idea of social determinants of health maps onto children with brain-based developmental disorders. And we thought that it would be important to develop a framework that would guide not only our own work, but that was relevant to others in the network, that we could come to a shared understanding of what social determinants mean. And we wanted to make sure that others in the network could see their work and themselves in this reformulation. At this point, I'm going to pass it on to Angela.
Thank you, Lucy. Yeah, so as you can see from the slides, is really answering the questions of, why this framework and for whom. So a framework that is meaningful for children, young people, families, and other relevant stakeholders. Now, for some of you, the Social Determinants of Health Framework, or SDoH, is a really well-known term, but I gather that some of you will not be as familiar as some other are with the term. And so I would like to perhaps walk you through some of the conceptual issues that we grappled with in our research. And in our research article that I think we can potentially, Anaik or Jonas, have a link. If you could copy paste that onto the chat box, that would be great. So social determinants of health is a conceptual framework that has been typically used to better understand factors influencing the presence and absence of disease and health conditions in the general population. In 2005, the World Health Organization, or WHO, launched a Commission on Social Determinants of Health. And this framework has since become the main way in which we think about the causes and consequences of ill health, and in particular, the ways in which we think about social conditions and environments that shape health outcomes and their patterns of distribution at the population level. In this sense, the SDoH framework departs from the idea that improving health depends mainly on the individual or individual bodies and behaviors, to consider, for example, how levels of income and access to housing and education, as Lucy was just mentioning, contribute to healthy or unhealthy lives. Oops. Apologies for this technical mishap there. Unpacking SDoH. So in our work, we sought to unpack the different elements that compose this conceptual framework. So what do we mean by the social, the health, and then the determinant component of SDoH? In our work and in the work of other colleagues in the social sciences, also in global and public health, SDoH has been an important framework and conceptual toolkit, but it's not always clear what we mean exactly by these social and social determinants of health. Is it about everyday social and family life, about environmental conditions for health, about historical and structural inequalities that shape our health, or a combination of these factors? The notion of determinant is also challenging in our particular research field because it seems to imply linear relations between variables linking causes and consequences, whereas one might also refer to cofactors and mediators, and in the case of childhood neurodisability, to transactional pathways of development, embodiment, and social participation. Last but not the least, the notion of health is also one that we grappled with, because in some instances or in some typologies and models of SDoH, it seems to imply more the absence of disease or focus on physical health. Although in the WHO Constitution, health is defined as an overall state of social well-being. So does this broader notion of health and well-being include living conditions, where one lives, learns, works, plays, ages, that allow us to live well? And we believe that's the case. So in this broader sense of the term, The idea of improving health and well-being implies the transformation of social conditions or paying attention to the social structures that allow us to live fairer and healthier lives, an aspect that is then intimately linked to notions of social justice and health equity that interest many of our colleagues here at the IHSP. Now, existing typologies and SDoH models draw on educational, socioeconomic, and psychosocial factors, among others, that influence patterns of health and the unequal distribution of disease at the population level, as I mentioned. But it is difficult to ascertain how and to what extent this conceptualization resonates for people that have a prior condition or a disability that alters their health, development, and everyday life, as well as the lives of their families. So the conceptual and contextual relevance of the SDoH framework may be limited when applied to specific transitioning groups, such as children and young people. And this application has actually been largely uncharted in the context of childhood neurodisability. And this is where precisely our research comes in and what we try to explore in the work we'll be presenting today. Another important conceptual aspect of our work is the very definition of childhood neurodisability. Children and young people with neurodisabilities represent approximately 9% of this population in Canada, and as far as 13% in the US, as reported in some recent studies, and include conditions that are associated with diagnoses such as autism spectrum disorder, cerebral palsy, epilepsy, and developmental delay. These include a wide range of largely pre-existing as opposed to acquired conditions that may affect cognition, behavior, communication, sometimes in complex and severe ways. Childhood neurodisability spans the developmental and mental health divide. And the term implies a dimensional and non-categorical approach that differs from that of individual neurodevelopmental disorders. This approach has been used since at least the 1980s in the work of Stein and Jessup, and then further conceptualized by Chris Morris in the UK. And it has been used to include different kinds of conditions that share similar challenges and forms of impairment, as well as caregiving experiences and needs, regardless of individual diagnosis. In our work, we have extended the medical definition of neurodisability as a brain-based impairment or neurobiological impairment to consider the ways in which impairment, quote unquote, interacts with environments and their affordances or barriers in ways that shape the rights and opportunities of persons with disabilities to participate in society, as is highlighted in the UN Convention on the Rights of Persons with Disabilities. This consideration warrants a social and ecological perspective on what it means to live with a neurodisability. So in our work, we consider the person in environment in ways that go beyond this medical model of individual disease, disorder, or diagnosis. This approach, or extended conceptualization, also encourages a non-normative and pluralistic notion of health equity and social justice that includes notions such as neurodiversity and disability rights and identities, including the right to live, to different ways of being, growing, and developing, and to live one's life in non-neurotypical terms. Now, in our attempt to remap this conceptualization of social determinants of health, we grappled not only with what's the social, what's the determinant, and what's the health component of SDoH, but also how this framework relates to other constructs in the field, such as well-being and quality of life or health-related quality of life. Because the SDoH framework has been focused often on health outcomes, statuses, and improvements, it has, in some instances, failed to capture what is at stake for and what matters the most for people living with neurodisabilities and their families and caregivers, which is the idea of living well and living a life of quality in meaningful ways. that might be, as I mentioned, non-normative and non-neurotypical. It is important to say that in our study, the participants and stakeholders mentioned this idea of living a life of quality that is not necessarily how we define in more technical terms quality of life or QOL measures. So this very idea challenges SDoH and also definitions of well-being when this is defined, for example, as a level of contentment or satisfaction derived from optimal functioning. It also challenges technical and sometimes decontextualized definitions of quality of life and health-related QOL that are often indexed to measures of physical health and ability. For example, the child and youth version of the International Classification of Functioning, Disability, and Health defines quality of life as a composite, emergent, and changing phenomenon of all aspects of functioning that may be impacted by a person's health condition, other personal factors, and environmental factors. There are useful elements within this modified version and definition, and in fact, importance is placed on the conceptual compatibility between quality of life and health/disability, where QOL refers to what people feel about their health condition and its impacts from a subjective perspective, and the latter refers to objective or exteriorized signs. Yet, as our colleagues in this field have noted, there's a challenge with this conceptual differentiation between quality of life and health, particularly when it comes to measurement, and the results and findings of some studies support how confounded these concepts are. Several scholars have also identified multiple conceptual and measurement issues in reviewing these models and frameworks of quality of life as applied to children and youth with developmental disabilities. So we are cognizant that some of these constructs imply an artificial dichotomy between objective and subjective measures of life quality and internal and external dimensions, as they separate outcomes and statuses from aspirations and views, and disconnect then lived experiences of neurodisability from living environments. These dichotomies and binaries are difficult to reconcile in practice and in our research when mapped onto the context of childhood neurodisability, a context where experiences of disability may be jointly produced with one's sense of identity, for example, neurodiversity. And among children and young people, these experiences are also shaped by circumstances, care practices, affordances, as some disability scholars have put it, that are determined by parents and caregivers, which means that these experiences cannot be fully understood if they're framed in terms of social functioning and notions of individual autonomy that are able-bodied and culturally normative. So some of our work dovetails nicely with this idea of how can we reimagine some of these concepts and processes, mapping SDoH onto the field of childhood neurodisability. Well, our argument is that broader and more situated definitions of health and pluralistic notions of well-being are needed and enable a reconceptualization of conceptual frameworks and existing typologies of SDoH in ways that account for contextual, relational, and ecological dimensions of neurodisability, and what our study participants call the life of quality, that is life as a whole, not only a life lived with or hindered by disability. In our evolving and conceptual framework that we will present very soon, there are some important implications. One is that people and stakeholders can be seen as the best judges of the qualities of their own lives. So it's important to engage children, young people, families, and caregivers. We also would like to note that the idea or the conceptualization of social and health justice can be seen in this particular context in more relational terms that encompass forms of health and care interdependency rather than those advanced by the biomedical model, which focuses rather on patient autonomy. And we will show how this translates in our framework into putting the child or the individual and or family at the center of the framework. It also warrants attention to material and structural conditions for leading a good and meaningful life. Now, this social or ecosocial perspective has been advanced as Dr. Lach and I discussed in the social sciences and in the health sciences literature. So it's not new. It has been defended in social work and psychology, in the fields of transcultural psychiatry, environmental science, public health, and even social epidemiology, as exemplified by the work of Nancy Krieger and her particular take on the use of ecosocial theory. From this vantage point, when we talk about an ecosocial SDoH framework, we talk about a framework that considers biological variables, social determinants, and interactive processes across domains, ranging from the developmental to the environmental level, and at different levels or scales of the ecosystems or the environments in which we inhabit, ranging from family to community to public policy engagement. So one of the key advantages of using this ecosocial approach, if that's an accurate description, alongside an extended and non-categorical definition of neurodisability, is that it allows us to critically engage with the social determinants of health and well-being in a manner that is inclusive of a broader range of disabilities, including those that might be less prevalent or even rare, and that is contextually and conceptually relevant and meaningful for children, youth, and their families, as we explore in the next slides. Over to you, Lucy.
Okay, is it this is me, right, Angela?
Yes, over to you, that's you.
Okay. So I'm going to now describe the process that we went through to come up with the framework, ultimately to come up with the framework. This may be of interest to others who are thinking about these kinds of ideas and concepts in relation to Alzheimer's or aging or people with severe mental illness. It's a process that can be followed in other substantive areas for sure. So in the first stage, what we did is we were fortunate enough to come across a compendium that had been published in 2015 by the Canadian Council on Social Determinants of Health that actually presented and reviewed 36 different frameworks that they had gathered from the gray literature and other sources that were, some of these frameworks were international, some had a national focus, some were very local. And we also conducted a secondary analysis of reviewed studies and frameworks to identify additional key scholarship. And so in this second stage,
that's when technology doesn't help. I clicked and it went back. There you go.
So can you click again? Yeah. So the second stage, once we'd located the literature, was really doing the embarking on a qualitative inquiry process to drawing on two established approaches, Jabourin's conceptual framework analysis and Walker and Avant's procedures for concept analysis and development. Can I have the next slide, please? So these are essentially the steps that we followed. So the first step, of course, as I've already indicated, was mapping or selecting the data and so we decided to work with these 36 frameworks and we read them deeply and began to pull out what the key concepts were. But in doing so, we also identified what the purpose of the frameworks were, as well as what the focus or the orientation of the frameworks were. So for example, a framework may be, the purpose of a framework may be explanatory, where it's trying to describe certain determinants of health. It may be action-oriented, the frame, or have an action-oriented purpose, where it describes action or entry points for intervention. Or it may be interactive, where it's not just a typology of determinants, but the determinants actually interact with one another and their demonstrations of the pathways among the determinants. Alternatively, the focus or the orientation may be, we identified whether it was on a specific, did it have a focus on a specific population like First Nations, or on children, or on people with X or Y, whatever. Whether there was, whether the framework was focusing on a particular issue or aspect of determinants of health, et cetera. So you can see that there was a coding that happened, but in the key part of it was really the deconstruction of the concepts that were embedded in each framework. So identifying key concepts and then generating a narrative about kind of what we saw in this model. What was this model about for us? And that's the features of the model. And then reflecting together on what did we like about this? What aspect of this model, what key concepts or processes did we think we were interested in working with going forward in our own conceptualization of the social determinants of health of kids with neurodisabilities. And then we also mapped what did we think the limitations were. And we did this for each of the 36 frameworks, and this can be found as a supplementary publication to our main article. So we categorized the concepts, we began to integrate them, we began to synthesize and resynthesize the concepts until they made sense to us. And finally, we came up with an initial draft of the framework, and then went on a process of validating the framework through an iterative consultation. I think we went through 13 different versions of the framework as we brought the framework out to parent groups, to self-advocates, to researchers in the community, representatives of community organizations, decision makers, policy makers, and practitioners. And each, we wanted people to be able to see themselves in the framework and comment on it, and we revised accordingly. So the resulting framework really does, there's some interesting aspects I think that we focus in on. One is that as Angela noted earlier, putting the child with a neurodisability at the epicenter of the framework was a non-starter for parents, for researchers, because of the relational interdependence on the child well-being and the family's well-being, or the life of quality that the families wanting to live obviously is so intertwined and interconnected with the child's life quality that that they ended up being at the center. We integrated and refined concepts such as lifespan, that this is a framework that can be used potentially over a lifespan, integrating notions of kinship. We also included and reformulated these, what we call intervening factors, which I'll describe to you as we take a look at the next slide. Angela, was there anything that you wanted to add to that?
Let me just go back 1 second. No, I think that's about it. Maybe we can just, this is just an exemplar of some stakeholder meetings and navigation related meetings we had just to illustrate that process. And I think we can jump now into the diagram, so the framework itself.
Okay, so at first glance, the framework is, of course, very busy, but I'm going to break it down for you. So the left side is we refer to as the explanatory hemisphere, and the right side as the action-oriented hemisphere. So some of the frameworks that we reviewed had one or the other, and some had both. And we landed on, we need one side of the framework to help us to understand what are the factors that conspire or are involved in creating a life of quality for the child and family. And the right side, we felt was also important to identify what are the processes involved in changing any aspect of that child's or family's life of quality. So, and I'll be providing you with an example of that. So in the middle, we have the child and family, of course. We have the sociocultural determinants that are, that have to do with the child's identity, the resources of the child and family, as well as the interpersonal resources and social capital like kinship and friendships and family, school, and or work relationships, supports and services. On the left side are policy and structural dimensions. So we really felt it was important to identify the role that these kind of macro level factors pertaining, for example, to housing policy or to healthcare policy, social care policies, and the role that those policies play in affecting and impacting the individual and family's life. And on the right side, we have community assets and environmental dimensions. So those are things like access to housing, access to transportation, recreational, social, leisure activities, quality of the neighborhood, the nature of the school, access to employment opportunities, also having an impact on the child and family's life. And in the middle, or surrounding the child and family, within that gray zone, we have things like values and rights and relevance and meaningfulness. And these are what we call the moderators or mediators. So to give you an example, the impact that housing may have on the extent to which the child and family are living a life of quality has to do with opportunities for housing. It may have to do with availability and accessibility of housing. So different aspects of the model light up for different factors at different times. So we have integrated this temporal component, this intergenerational component, and therefore a lifespan aspect. And of course, at the bottom of that explanatory hemisphere are the neurobiological and developmental determinants. Although some models did not include sort of the bio aspect, given what Kids Brain Health Network is and the nature of the research that's going on there, this was one of the key adaptations that we made to include aspects of the brain, the body, the genetics. All of those things are important, of course, as well. On the right side, so now I'm going to turn attention to the right side, and you could see here that we have along the top a set of boxes that really speak to the process of making change and the different levels of the ecosystem that are involved in shifting the needle on any kind of social issue. So individuals and families may be involved, communities and organizations may be involved, and obviously decision makers. But the idea being that creating any kind of social change it's very difficult to accomplish, if not impossible, by any single layer of the ecosystem. That there has to be a concerted effort to involve the individuals and families, to involve community organizations, and to involve decision makers and governments. And so I'm going to try and make this come alive for you by describing a navigation project that I'm involved in on the West Coast of Western Canada. That involves 3 different sites. It involves Edmonton and Calgary. Edmonton, Calgary is one site, Vancouver, and Whitehorse in the Yukon. And the issue that was identified for social change had to do with the ways in which families access and navigate supports and services. If you know anybody who's got a child with a neurodisability, you know that there are multiple systems involved in supporting that child and family potentially. There's the healthcare system, there's a social care system, the child and family system, at a regional level, at a provincial level, at a federal level, there's tax credits, there's all kinds of things that they have to navigate in order to adequately support that child. And the issue is so families have a difficult time finding where those supports are. They may not know what those supports, what supports to even look for, why they should be looking for those supports, and how to look for those supports. I mean, those are different aspects of navigating supports and services. And of course, once they access those supports and services, there often are tremendously long waiting lists. So what each of these jurisdictions did is they brought together, if you go, they identified this need for social change. Sorry, Angela, am I going out of sync here, or oh, there we go.
Oh, that's perfect.
They identified.
I decided to move forward onto navigation slide as a case study.
Okay, sorry. So what they decided to do is they identified a need for social change, that we need to change how families are navigating and accessing services. The core group brought together the champions in the field. And so these would be champions from the different sectors that I've just identified. And they began to talk to families about their experiences to establish among themselves a shared understanding of what the gaps were, what the needs were, what the assets were. And through these strategic partnerships and this kind of strategic inquiry, began to identify actionable items that they could work on together to implement changing how families navigate and access services. And of course, we came in with our research lens to help and sort of embarked on this kind of participatory approach with them to identify, help them identify what needed to be changed and to evaluate those changes as they were identified and as they emerged and as they changed, actually. So in the end, I think we've come out with, I think, some interesting core components pertaining to what if this needed to, or another jurisdiction wanted to embark on something like this, what's needed. Well, what's needed obviously are these bringing together people from across the sectors: education, health, social care, housing, justice in some cases, and bringing in also the NGOs. So the NGOs are organizations that represent autism or epilepsy or cerebral palsy, basically the leaders in the community, to develop a shared identity through a mission, a vision, developing a vision together, and I'm beginning to identify what goals they can work on after having mapped out what their assets are, after having established what the gaps are, given what the needs of the population. And so in the end, what Vancouver ended up doing is they, after realizing that they were diagnosing kids and sending them off out of the diagnostic center with a report, what they realized that the families were not accessing services and supports. They embedded in the report, there was information about what they were supposed to do, but months later, they were finding that the families hadn't done a thing. So now, so what they did is they developed a strategic partnership with Autism Information Services. And once the child was diagnosed, simple change, small change, once the child was diagnosed, the name and contact information of the family was shared with Autism Information Services, and they would reach out to the family to get the ball rolling for navigating access to supports and services. The other thing that they've done is that they have realized that people don't know where navigation lives in the province, and so they've set on a process to make navigation render it more visible in the province, by holding an initial summit on navigation and working towards developing a community of practice on navigation to build capacity in the province pertaining to this important service. I guess the other thing that this project has really helped us to realize is that moving the needle on navigation, so back to our map, is not just about making parents better navigators, services, not just equipping them with, okay, here are the tools for navigating. It's not just about infusing more navigators into the health and social care or NGO sector for that matter. And it's not just about creating better partnerships. It's if we want to move the needle on navigation, it is a multi-systemic phenomenon. It's got to happen at all layers of the system. And that's what we've learned from this project is, and that we can certainly take forward to others and are starting to take take out to other jurisdictions, in terms of going through a very similar process to this. So yeah, and identifying what those, what Alberta did was different and what the Yukon did was different, because what actually needs to change will vary from jurisdiction to jurisdiction. And so allowing for that kind of, this is not a recipe per se in terms of social change, it is a framework. And then the partners work within this framework to identify their own low-hanging fruit or their own priorities, their own goals. And that's what's, I think, really key and important in this, the second part of our framework here. Angela, on to you.
Thank you, Lucy. So what I did is I went forward in the slides because I reckon we were already talking about navigation. Do we want to say a little bit more about this artwork as well that we developed with participants?
Yeah, so we brought the three jurisdictions together back in the old days when we could actually meet in person, and we invited this artist to draw while people were presenting, and so we have this artist's rendition of the stories that we were telling, and this is the top one really is about the federal, the different layers of the system that families have to deal with, the importance of collaboration in the policy landscape. What else? I can't really see everything that's there, but it's that's the general idea, so that we could come back and that those actually end up being the minutes of our 2-day meeting, which we come back to often. And this the bottom one is the story about BC. About how they started off being quite chaotic, but developing certainly as this consensus on what is navigation. They kind of got stuck, and what they realized at this particular meeting is that they hadn't done together what the other jurisdictions had done, which was to arrive at a common set of values that will drive their work together forward. So after being stuck, they went back and had that discussion, and subsequently just took off, and they're doing all kinds of wonderful things. All right.
Okay. So just going a bit back in trying to bridge what we just presented, so the conceptual framework and the visual that accompanies it, I think it's worth thinking about the implications of this kind of proposal or conceptual framework for different areas, from research to, oops, this keeps popping up, practice, policy, and theory. So in our paper and in our research, we begin first by calling for a shift from the systematic use of health status and outcome measures to the development of more granular instruments and methodologies that would hopefully be time, scale, and or context sensitive. I think it's also worth noting that while the validation of this framework has been conducted from a child family-oriented perspective, as we just mentioned, we recognize that it may have a wider application in other domains of health and well-being, as well as across the lifespan, which would require obviously further testing and validation work in the field. Second, as Lucy was just describing through the case study of navigation and navigational supports in Canada, I think it's quite important to highlight the need for I mean, this is something that is said quite often in public, the need for cross-disciplinary and intersectoral engagement. But doing this engagement in meaningful ways is actually needed, and quite pressing in terms of helping us to understand what people themselves judge to be health, well-being, development, and living a daily life of quality. And also what are the social ecologies of these processes and material conditions and pathways that we just described in our artwork and visual descriptions. So participatory research action, as well as community and youth engagement, seem particularly relevant approaches, but others may also emerge in the future. Third, our ecosocial framework, which is a conceptual framework, but also an evolving and dynamic one. So we don't see it as something stable or fixed, right? It can be adapted for future circumstances and evolving conditions. It comprises these two hemispheres. So the left hemisphere that we were just showing, that has more explanatory elements of SDoH, and more action-oriented elements were included in the right hemisphere. And it's interesting because we include advocacy and community and policy engagement as intrinsic elements within the ecosystem in recognition of the efforts of families, parents, and caregivers in this domain as well. Those two are part and not external to social determinants of health. And so in doing this, the proposed framework seeks really to capture the dynamic interplay between those two hemispheres in ways that shape experiences and pathways of neurodisability. While they are seen as primarily mediated by the family, we also insisted a lot on this idea that they are socially and politically determined and variably distributed across geographic areas and discursive space-time. And this is to say that there might be, in fact, variations that result in social and health inequalities. And so in this sense, we argue that it's very important to pay attention to these structural or infrastructural contingencies and the role of public policies, not only acting as determinants of health and well-being, but also as mediators and means of change. For example, policy reforms and allocation of funding or different funding priorities will shape the availability and accessibility of health services and social supports in different jurisdictions. And these will in turn have an effect on pathways and experiences of neurodisability, whether it's across transitions from school into adulthood and the employment market or over the lifespan. Finally, a point that I think it's worth considering is the ways in which this research also not only contributes to practice and policy, but also to the development of what some people in the field, including ourselves, Nancy Krieger, and many other colleagues, have talked or described as ecosocial theory or social ecological approaches. Why? Because they not only consider aspects of moral agency, the role of advocacy and family advocacy, as we were saying, they also help moving up accountability and responsibility for social and health inequalities from the individual or the group to the governmental level. And so in the next slides, as we went through, I think already some of the aspects of navigation as they map onto our conceptual framework. Is there anything you would like to add to this, Lucy, at this moment?
Yeah, well, I don't think so. I think I'd actually be interested in opening up because we've got only about 7 minutes left.
We don't have a lot of time left.
Really interested in opening up. I mean, I am working with a group, starting to work with a group here in Montreal around the issue that we're focusing on has to do with transition into adulthood. You know, we have many people with intellectual disabilities and autism who are unemployed, at home, with aging parents, with no plan. I mean, the government has no plan for these people, no plan around housing, no plan around employment. This group I've created this group here in Montreal to begin to tackle these issues. And so I'll keep you posted on how that's going. But it's a ticking time bomb as far as I'm concerned. And so I'm sort of the person that's on the closer to the ground, kind of trying to mobilize people, but there's a conceptualization behind what we're doing and how we're doing it. For these families and advocates, it's this is the issues of housing, employment, continuing education, leisure are their main preoccupation. I know somebody had asked me, how do you think the new Accessibility Canada Act, and what impact will that have? I guess that remains to be seen. The relationship between kind of federal level legislation and then what's happening provincially. And in fact, in this province, we don't even have like a disabilities table where education should be speaking to health and social care, who should be speaking to housing. I would, so that kind of advocacy needs to happen. I think we're pushing for it from the ground up. But the extent to which that then maps onto the accessible, I don't know. That remains to, I think it's still early days. Angela, did you want to?
No, I just put up this final slide, but I don't think there's maybe enough time for it in terms of a case study. But just I wanted to bring up some questions that relate SDoH with issues of social and health justice, and just leaving those questions up there to open up the discussion, open to the floor. And, just highlighting how some of these things have played out in really complex ways in times of COVID and pandemic living, where, for example, accommodations such as, distance learning, remote working, telehealth, special benefit schemes, disability supports had been, requested and fought for many, many, many years. And then COVID comes, and what seemed impossible was made possible quite quickly. So it really shows how, policy action and rapid responses can have a direct effect on the lives of people and their daily living conditions. And other questions such as these people and groups not being prioritized initially for vaccination, not receiving enough PPE, also the rollback or sort of challenges that some people experienced with being called visitors instead of long-term essential family caregivers. And so there was a whole movement on social media, I'm not a visitor. And so really COVID intersecting with neurodisability played out in really complex ways that I think are worth discussing. So yeah, I can stop share my screen. I think we would love to hear from you on your own fields of experience and research, how these things play out.
Okay, well, thank you very much for your very interesting presentation. So we don't have a lot of time, but I'll convey some questions so that you can deal with them as you see fit. So there was one participant who was asking how you think the Accessible Canada Act may impact landscape for families.
Yeah, it's interesting. I know that there was a huge consultation process that went into the Accessible Canada Act, and they spoke a lot to families. I think I tried to address that earlier to say, there's the focus on telecommunications and transportation. Maybe we'll see how down the road how provinces pick that up, and how. But I'm not seeing it. I don't know. I honestly don't know. I don't know.
Okay.
If if this group, here in Montreal is saying our priority for our aging adults with intellectual disabilities, with neurodisabilities is their, living a life of quality is highly contingent on them having a source of income, having access to housing, having access to care, having access to some kind of meaningful employment to the extent that that's possible. I'm not seeing those things addressed really in the Accessible Canada Act, but maybe I'm missing something.
Yeah, yeah. Or perhaps as far as I know, or perhaps it's because the access to maybe it wouldn't include enough. Maybe it's too early to say how it will cash out in the future, but also maybe just on the basis of its structure, it may force employers to offer more opportunities, but it's not clear that it would necessarily provide programs or supports that you're mentioning. And so, well, I had a question myself, which was because I found that fascinating that you're trying to develop a framework that address the social determinants of health in novel ways that better respond to the realities of families of people with neural disabilities and their families, and so I was wondering if you saw a big contrast between between the social determinants of health of non-disabled children and social determinants of health of children with neural disabilities. What was the thing that struck you most, or perhaps that surprised you most on your finding? Because we all need housing, or we all, but perhaps through your research you saw that children with neural disabilities and their family had that particular needs that is either more important or was more surprising to you, by contrast to non-disabled people.
That's a really good question. Does this framework lend itself to being generalized beyond children with neurodisabilities? I mean, we certainly, our analysis was through that lens. When we were looking at the frameworks, we were asking ourselves, how does this map onto? And certainly the idea that at the epicenter is this idea of living a life of quality. I think that the children and their families don't see themselves as being unhealthy. They see themselves, what's important to them is this sort of what they draw on to generate their own representation of their own lives, and the quality of their lives is, it may be different than there may be different from children who don't have brain-based developmental disorders.
Yeah, I think this discussion reminds me of an exercise we did on the top 10 support needs. I think some of the things that sound to me or seem to me quite specific are the necessity of respite care, of peer-to-peer supports, of particular kinds of supports and social networking that really help people. I was going to use the word cope, but cope maybe it's not the right word, to live well on an everyday basis, but also to access information in ways that are actually relevant for their needs when they need it, right? And so navigation is really that concept that speaks to a system that it's highly fragmented. And if we think about these experiences of neurodisability, these families are overburdened already with enormous duties of care, of being well themselves. So if we throw in pandemic leaving and physical distancing and all the changes that we've seen, I think we can only phantom what this means for those people. And so asking them what that feels like, what that implies, and also what would they propose from their own experiences as policy change would be quite important. And I think here I'm already answering the question from Frank Elgar on knowledge gaps and future studies. I think they have to be centered on ways of moving forward together that speak to what people experience and need. I don't think people need more, damage-based interventions or just, early interventions or purely fundamental research. I think we're at the point now where knowledge mobilization and policy change seems really pressing and doable.
Okay, great. Well, Frank, feel free to follow up if you have a follow-up question. Otherwise, Dr. Lach, do you have anything to add?
Yeah, it's a really, I mean, the issue of how policy changes is an interesting one, and the extent to which evidence is used or not, the extent to which policy change is a response to public inquiries or public, some kind of tragedy happening, as opposed to it being really something that is a function of people coming together to say, here's what's needed, here are the systems that you've created to help us, and here's how we're not working. So if you manage to create these systems, surely you must be able to do something to fix them. And so work with us to move the needle on these important social issues. It's a very pragmatic kind of perspective, but a really, really important one to communicate. In this province, as I mentioned, we don't have a disability table at the ministry level. We don't have a disability council. And so just to give you an example, even if social housing is very much needed for the people with intellectual disabilities and autism, but accessing those dollars is almost impossible. The second issue there has to do with rules. So if someone is living in social housing, they can only have, I don't know, something like 3 hours of support a day from the health and social care sector. Who makes these rules? These are rules that need to be, these kinds of barriers need to be challenged. So I think that we have a role to play in that.
Okay, well, thank you very much to our speakers. I'll certainly be following up with you individually on your interesting work, and I thank everybody and I thank everyone for having joined us. We are out of time, but so we will end the meeting now. Have a good day.
Thank you very much for the invitation and for us to present here. It was great.
Thanks so much.
Take care, everyone. Stay safe.